Going to begin with gastrointestinal pathology. So first we are discussing the oral pathologies. The first one is aphthous ulcers. Aphthous ulcers are also called as canker sores. They are common oral ulcers which are painful, swollen, and like round to oval ulcer covered by yellowish exudate. Actually, this shows the aphthous ulcers. Recurrent aphthous stomatitis is associated with celiac disease, inflammatory bowel disease, SLE, Behcet syndrome, and HIV infections. And next, coming to squamous cell carcinoma, you can see the white color is actually the leukoplakia white patch. Even red, if the same thing is in the red patch, that is called erythroplakia. Both these are precursors for squamous cell carcinoma. Squamous cell is the most common malignancy of oral cavity. It usually affects the tongue and it is associated with some tobacco, alcohol, HPV-16 virus, and also presents as non-healing ulcer with irregular margin and raised borders. And next, coming to ciliolithiasis. Actually, it is a stone in the salivary duct or major salivary duct which is draining the gland. So it is most common in submandibular gland. You know that salivary glands are three: parotid, parotid gland, submandibular, and sublingual. Among all this, parotid is the largest salivary gland. Okay, and in that, especially submandibular gland, you can find this ciliolithiasis. It is a stone and it is associated with salivary stasis. Saliva is not producing, so because of that there will be dehydration and also it will cause some trauma. Because of trauma also this problem may arise, and it presents as recurrent pre or periparietal pain and swelling in affected gland, of course, because saliva is blocked there. So treatment, you can give NSAIDs and hydration. And next, coming to Cialediditis, that is the inflammation of salivary gland. You can see the word here, Cialediditis. That is the inflammation of salivary gland due to obstruction or infection, especially Staph aureus, mumps virus, or some anaerobes can affect, and it is also due to some immune mediated mechanism like Sjögren syndrome. In this problem, there is loss of saliva, so that there is more infection and more cavities formation. Especially NAF staph can affect. We can give treatment for NAF staph and metronidazole and clindamycin. For staph aureus, we are giving NAF. Next, coming to salivary gland tumors. Actually, salivary gland tumors are divided into three types: pleomorphic adenoma, which is first most common. Next, Warthin tumor. Next, mucoepidermoid carcinoma. Actually, most of the salivary gland tumors are benign and they affect only the parotid gland. Next, followed by submandibular and sublingual. If any salivary gland tumor is related to minor salivary gland, then it may be malignant mostly. And typically, actually, these gland tumors are painless. They are not giving that much pain, but they are swelling and sometimes they will be mobile. Sometimes facial paralysis or pain may suggest malignant involvement. Why facial paralysis? Because it may involve the facial nerve. So first let us see the pleomorphic adenoma. It is a benign mixed tumor. Mixed tumor means mixed types of cells are found. It is mostly seen in most common salivary gland tumor. Consists of chondromyxoid stroma and epithelium. Actually, you can see this one is a pleomorphic adenoma. So it is mainly containing chondromyxoid stroma and epithelium, and reoccurs if incompletely excised or ruptured intraperitoneally. It may undergo malignant transformation, that is painless mobile mass. Irregular margins are present. Risk is prior radiation. If you remove this tumor also, if some of the tumor is left over, again it may reoccur. Okay, so it is composed of chondromyxoid stroma. And different types of cells. You can see here the dark and crowded cells, here light, and so it's having a pleomorphic adenoma. Next, coming to Warthin tumor, it is papillary cyst adenoma lymphomatosum. It is benign cystic tumor, mainly seen with germinal centers, maybe bilateral or multifocal. Typically, it is found in people who smoke, like 8 times more common in smoking people, and it is second most common. Next, coming to mucoepidermoid carcinoma, it is also most common malignant tumor. It is mucinous and squamous. In the name you can see mucinous and squamous. Carcinoma may be involved here, squamous components, and also there are intermediate hybrid cells which are involved. It may invade the facial nerve and cause pain. As we said before, malignant may invade the facial nerve and pain, and also seen in minor glands. again for this also the risk is radiation. One more condition which can affect salivary glands is mumps. Mumps is causes parotitis, mainly affects parotid gland. It is an RNA virus. Let us discuss something about saliva also. Saliva is actually 90% water. It also contains mucin. It is having IgA antibody and it contains lysozymes, lactoferrin, and also saliva protect our tooth. Actually, saliva is a part of innate immunity. In saliva, have alpha amylase, it's used to digest the carbohydrates, but mostly it is present in the pancreas, right? And also it contains lingual lipase. Next, one more thing about saliva is saliva contains the echiner cells and ductal cells. So echiner cells mainly produce saliva similar to the plasma, so same concentration as plasma. But ductal cells, they remove the sodium and chloride and add bicarbonate and potassium to saliva. So they alter the saliva, they make it hypotonic saliva. Why hypotonic? Because of removal of sodium and chloride. Next, increased flow rate. Whenever there is increased flow rate of saliva, the ductal cells are not involved. So saliva is isotonic to plasma. So whenever there is more flow rate, ductal cells are not involved. So it will be similar to plasma, because echiner cells, in echiner cells, saliva is similar to plasma. Ductal cells only modify the plasma. That is, they make the saliva hypotonic. Next, coming to M1 and M3 receptors are most important, have great effect on the saliva. That is, M antagonists like atropine, scopolamine causing dry mouth. Whereas M receptor agonists are pilocarpine, cholinesterase poison. They increase the salivation. Now let us go to eclasia cardia. Actually, this is a problem of lower esophageal sphincter. It is failing to relax. So because of that, you can see the dilated esophagus here. It is appearing like a bird beak, right? Which is seen especially because of distal stenosis. Okay, the manometry. In the manometry, you will see this bird beak, formation. It is because of uncoordinated and absent peristalsis with increased lower esophageal sphincter resting pressure. Okay, so in barium swallow, when you do the barium swallow, you can see this. Treatment is surgery or endoscopic procedure. That is, you can give botulinum toxin injection. Because of this accumulation, the food also accumulates in the esophagus, and that will cause a bad breath. Actually, the eclasia can be either primary eclasia or secondary. If it is primary, it is idiopathic. Secondary is associated with Chagas disease. That is a T. cruzi infection or extra esophageal malignancies like mass effect or paraneoplastic can also cause. But the Chagas can cause eclasia, which is important, especially in Orbach plexus, the muscle layer. The muscular layer of Orbach plexus is involved here. And the patient symptoms are like progressive dysphagia to solids first, like they can't swallow solids first, later following to liquids. So mainly versus obstruction, primarily solids, associated with increased risk of esophageal cancer. Of course, if this is blocked like this for longer time, it will turn into cancer. Next, let us see GERD, that is gastroesophageal reflux disease. In the name itself, you can see the gastric contents are coming into the esophagus. Why? Because there is a problem in the lower esophageal tone. That is a decrease in lower esophageal tone, so that all the gastric contents are coming back into the esophagus. And you can understand esophagus is unable to bear this acidic contents, so that it may present as heartburn, and it also may lead to regurgitation, dysphagia, and also may present as chronic cough, hoarseness, that is laryngopharyngeal reflex, and it is associated also with asthma. So complications include erode esophagitis, like erosive esophagus will become erosive in the mucosal layer, and it may also form strictures, and also it may form Barrett esophagus. And next, in pediatric people also, in small children, you can see because of immature LES, so that there will be always vomiting and crying. GERD risk factors are alcohol, smoking, obesity, coffee, hyatelurnia. You know that the gastric cardia is coming out into the esophagus. And treatment is weight loss and Nissen fundoplication. That is a surgery procedure. We try to take the fundus of the stomach and try to make the lower esophageal tone better, so that the food will not go up into esophagus. And also you can use a proton pump inhibitor, so that you can somewhat decrease the acidic content in the stomach, so that it will not affect the esophagus. Now coming to esophagitis, in the name itself you can see that is phagitis means inflammation of esophagus, especially the base will undergo hyperplasia, and the lamina propria, the papilla will elongate. It is also associated with reflux infection like candida candida will form white pseudomembrane. In this diagram you can see this is a candidal infection of esophagus, white pseudomembrane is formed. And also HSV1 will form punched out ulcers, cytomegalovirus will form linear ulcers. These are important. HSV1 punched out, CMV linear, candida white pseudomembrane. Okay, and some caustic injection, some lye injection, pill induced esophagitis, like all these drugs, iron, potassium chloride, bisphosphonate, tetracycline, NSAIDs, and eosinophilic esophagitis. Here eosinophils are involved. Infiltration of eosinophils in esophagus present with atrophy. Etiology is multifactorial. Food allergens, dysphagia, food impaction, esophageal rings and linear furrows are seen on endoscopy. Eosinophils on biopsy. Main thing is eosinophilic esophagitis. Next, esophageal strictures. It is because of caustic injection, acid reflux, esophagitis. Here lye is causing especially liquefative necrosis which cause strictures. So strictures are because of especially lye, it is causing liquefaction necrosis. Next, Plummer-Vinson syndrome. Actually it's a triad of dysphagia, iron deficiency, anemia and esophageal webs. There is increased risk of esophageal squamous cell carcinoma associated with glossitis, mainly seen in middle-aged white female. Next, Mallory-Weiss syndrome. Actually, there is a partial thickness longitudinal laceration that is important here of gastroesophageal junction. So it is confined to mucosa, submucosa, mainly due to severe vomiting like condition. This is formed and often present with hematemesis, abdominal back pain, found in patients with alcohol use and bulimia nervosa. Actually, here the tear you can see in the Mallory-Weiss syndrome or Mallory-Weiss tear. There is a tear in the longitudinal laceration of GE junction. So because of that it may also cause hematemesis, that is a blood vomiting. Next, coming to esophageal varices, that is a dilated submucosal veins of esophagus. It is also related to portal hypertension because portal veins are having a communication with this, especially seen in the lower 1/3 of esophagus, secondary to portal hypertension. So you can see here this one, the red arrow here represents the dilated submucosal veins of esophagus. Because of portal hypertension also this may happen, and that will lead to life-threatening hematemesis. So treatment is endoscopic banding. We do the banding of this blood vessel so that we can stop the bleeding. Next, coming to distal esophageal spasm. It is called diffuse esophageal spasm. It is a spontaneous non-peristaltic contraction of esophagus with normal lower esophageal pressure. So it presents with dysphagia, angina like chest pain, barium swallow may reveal corkscrew esophagus. That is because here everything is normal but the esophagus will become stiffened. So that's why it is called distal esophageal spasm, and that will cause corkscrew esophagus. Manometry is diagnosed and treatment nitrates and calcium channel blockers. So this is also called as angina like chest pain. Okay, angina like chest pain seen in distal esophageal spasm. Next, scleroderma, esophageal involvement. That is a smooth muscle atrophy of esophagus, decrease lower esophageal pressure and distal esophageal dysmotility, and that is leading to acid reflux, dysphagia, again stricture, Barrett esophagus, aspiration, part of crest syndrome. Next, esophageal perforation. It is most common iatrogenic following esophageal instrumentation. So for esophagus, either for diagnosis or for treatment, we are sending the instruments into the esophagus. So because of that, sometimes it may perforate, and some other non-iatrogenic causes like spontaneous rupture, foreign body ingestion, trauma, malignancy. So it will present with pneumomediastinum because perforation from the esophagus you will directly enter into the mediastinum. You can see these red arrows. So this is the esophagus. You can see the perforation. You can go into aortic arch or you can come directly into this mediastinum. That will lead to subcutaneous emphysema due to dissecting air. Signs include crepitus in neck region or chest wall. Next, coming to another syndrome, that is a Bohr-Heave syndrome. That is a transmural rupture of esophagus of all the layers. You know that esophagus have mucosa, submucosa, okay, muscularis externa. So if all the layers are ruptured, that will lead to Bohr-Heave syndrome. Transmural, usually distal esophageal rupture due to violent retching. Retching, like if you have sudden vomiting, so much forceful vomiting, then sometimes whole layers of your esophagus may rupture. Now coming to Barrett esophagus, you know this, everyone know this, like because GERD, like a lot of stomach contents are coming to esophagus, so esophagus will try to change its epithelium. You know that the normal epithelium is replacement of non-keratinized stratified squamous epithelium with intestinal epithelium, that is non-ciliated columnar with goblet cells. So you can see the goblet cells here. Actually goblet cells should present in the stomach, but these goblet cells are coming in this lower esophageal junction, squamo-columnar epithelium junction. Actually this is a squamous, this is columnar, but this columnar epithelium is coming now here into the esophagus. So this will lead to esophageal adenocarcinoma, higher risk of esophageal adenocarcinoma, mainly due to chronic GERD and also associated with adenocarcinoma. So esophageal cancer is squamous cell or adenocarcinoma, increased risk in smokers. It is present progressive dysphagia, that is first you can't take solids, next you can't swallow liquids, and also associated with weight loss, aggressive course, lack of serosa in esophageal, allowing rapid extension, poor prognosis due to advanced disease at presentation. So squamous cell carcinoma in esophagus is most common in upper two-third region. That too, it is seen mainly also in the middle region. Risk factors are alcohol, hot liquids, caustic strictures, smoking, eclampsia. If you take hot liquids, what happens? If you continuously take hot liquids, the epithelium, the normal squamous epithelium may get changed, and that will lead to squamous cell carcinoma. And prevalence is more common worldwide. It may also lead to hoarse voice and cough. Whereas adenocarcinoma is affecting lower one-third where there is GERD. This causing Barrett esophagus. Because of that, the glandular layers are formed, and that is leading to cancer. Chronic GERD, Barrett esophagus, obesity, tobacco, smoking. More common in America. So in America, adenocarcinoma is most common. Lymph nodes of this esophagus, upper esophagus, cervical, middle esophagus, mediastinum, tracheobronchial, lower esophagus, celiac and gastric. Next, if the mucosa obstructs in the lumen, in the upper esophagus, it will cause webs. In the lower esophagus, it will cause rings. Risk of squamous cell carcinoma. Very important. Upper esophagus, webs. Lower esophagus, rings. So, Shadzaki ring is a ring at squamo-columnar junction. Here only, in this location only, if you get some ring-like structure, that will lead to dysphagia to especially solids, and that is squamous mucosa proximally and columnar distally. So squamous mucosa will be proximally and columnar will be distally, and that will cause Shadzaki ring. As I drawn with this pen, you can imagine this as Shadzaki ring. Now let us discuss about gastritis. Actually, gastritis is inflammation of mucosa that lead to increased acid damage to the mucosa, because there is more production of acid when there is inflammation of mucosa. So this gastritis is divided into acute gastritis and chronic gastritis, and chronic gastritis is again in turn divided into type A, that is autoimmune, and type B, that is due to H. pylori. So acute gastritis, in the name itself you can see it is acute, so the neutrophils are involved here. It is mainly caused by NSAIDs use, because NSAIDs actually decrease the prostaglandin. As they decrease the prostaglandin, that will decrease the gastric mucosa, so the protection is gone. So when the protection is gone, easily the substances like alcohol or some other substances, they can easily damage the mucosa, and that will lead to increase in acid. And burns, why burns are affecting? Because burns lead to hypovolemia, so there will be low blood supply to the mucosa, and mucosa will undergo ischemia, and that will lead to again loss of protection, more acid. And next, brain injury is Cushing ulcer, that is increased vagal stimulation. So whenever the brain is injured, the vagal stimuli is activated, and that will lead to increased acetylcholine, and that acetylcholine will lead to increased hydrogen production, that is acid production. So this is a acute gastritis, and here the common among patients with alcohol, taking daily NSAIDs, that time we need to remember. And of course dyspepsia, that is nausea, vomiting and loss of appetite, abdominal pain. Food intake, increase hydrogen, worsen the symptoms, because already there's more hydrogen, so if you take food, again more symptoms. And Paneth cells are present in body and fundus of the stomach, that you need to remember. Now coming to chronic gastritis. Chronic gastritis, in the name you can see chronic, so lymphocytes, plasma cells, macrophages are involved, and this is a mucosal inflammation leading to atrophy. So because of atrophy there is hypochlorhydria but hypergastrinemia, and that will lead to intestinal metaplasia, increased risk of gastric cancers because low chlorine, high gastrinemia, so that is linked to high acidic condition. So here the causes of chronic gastritis is H. pylori or autoimmune. First let us see type A, autoimmune. The autobodies are T cell induced on hydrogen potassium ATPase on parietal cells and also to intrinsic factors. So this will lead to increased risk of pernicious anemia. You know that generally B12 will absorb in terminal ileum. If there is no intrinsic factor, then how will it absorb? So it can't absorb. And remember that uh, more common in female in body in fundus. It is associated with HLA-DR antigen and it is positive for gastric adenocarcinoma. That is, it may form a gastric adenocarcinoma. It will affect the body and fundus of stomach. Next, coming to H. pylori, it is type V. Actually, gram-negative rods can cause this. It is a B cell cancer. Well, malt lymphoma can cause this. It is most common increased risk of peptic ulcer disease. Type B H. pylori can cause the peptic ulcer disease by increasing more hydrogen. It is urease positive. It is actually ammonia protect the bacteria. So ammonia will increase the gastric, increase gastrin, increase hydrogen, that will lead to increase pH. Affects andrum first and spreads to body of stomach. So first andrum is affected. Next body of stomach is affected because in the andromal the G cells are present. If that gets affected, it will lead to activation of more G cells, more gastrin, that is leading to more hydrogen release from the body of the stomach. The diagnosis can be done by urea breath test, biopsy, and also you can take the stool antigen. So remember that H. pylori autoimmune both can lead to increased risk of adenocarcinoma. Meyenter's disease is most common in male. Meyentery male, MM, okay, and it is leading to hyperplasia of gastric mucosa. There is hypertrophied rugae. The rugae are hypertrophied. This red arrows you can see. It's a wavy like a brain gyri. They look like brain gyri. Causes excess mucus production. Here the problem is more mucus production with resultant protein loss and parietal cell atrophy with decreased acid production. So parietal cell will completely go atrophy. So no acid at all, but more mucus, and also this protein loss. This is precancerous. Patient have weight loss, anorexia, vomiting. Why vomiting? Because there is no acid. How to digest the food? So there will be, you can't digest the food. There will lead to anorexia, weight loss, epigastric pain, edema. Why edema? Because all the proteins are lost. And you can remember this wave. So Meyenter's disease will cause a wave of diseases like that. You can remember most common in male. There is Meyenter's means remember mucus, more mucus, no acid. Okay. H. pylori, for H. pylori actually there's a 3 type of therapy we can do. That is hydrogen pump inhibitor because there is more acid there. You can do clarithromycin and amoxicillin. Now coming to gastric cancer. Gastric cancer, you know the most common cancer is adenocarcinoma. Okay, 95% it is adenocarcinoma. Next you may get either lymphoma or GI stromal tumor, carcinoid, all these are rare. So early aggressive local spread with the nodes or liver metastasis. Liver metastasis is most common for gastric cancer. It is associated with acanthosis nigricans and insulin resistance and malignancy. So often presents late, but it have the weight loss symptom, early satiety, abdominal pain, obstruction, and in some cases acanthosis or lesser terral sign. What is lesser terral sign? It is multiple itchy seborrheic keratosis caused by cytokines. Actually here some inflammatory markers cytokines are released and that are causing itchy seborrheic keratosis. Okay, you can remember this as weapon. So gastric cancer weapon, Meyenter's disease is wave. So actually it's like a same problem in gastric cancer also. There's like a lot of weight loss, early satiety, abdominal pain, obstruction, and intestine is associated with H. pylori, dietary nitrosamine, like whoever eat more smoked foods, especially in Asian countries, tobacco smoking, echlorhydria, chronic gastritis, commonly on lesser curvature. Looks like ulcer with raised margin in older membranes. In older people you can see this most common, and type A blood group have more of this because they're having increased auto immunity gastritis and also associated carcinoma. Next there's another type, that is a diffuse gastric cancer. It is not associated with H. pylori. It is mainly due to E. cadherin mutation. Here the signet ring cells are seen. This signet ring cells you can see only upper ring like lower. You can see these are signet ring cells. These are the mucin filled cells with peripheral nuclei. This is a peripheral nuclei. This is a mucin filled cell. and stomach wall grossly thickened and leathery, that is called linitis plastica. Okay, here also early cystitis is most common, metastasis is most common to the liver. The very important notes are which shows not Krukenberg tumor, Sister Mary Joseph nodule, Blummer shelf, which show no involvement of left supraclavicular node by metastasis from stomach. Supraclavicular, this is clavicle, above clavicle, the node is involved. Krukenberg tumor is metastasis to ovary. Actually, this gastric cancer only can go to all these places. It can go to ovaries, in bilateral ovaries, abundant mucin secreting signet ring cells are present. Sister Mary Joseph nodule is subcutaneous periumbilical upon umbilicus, okay, metastasis. Blummer shelf is palpable mass on digital rectal examination suggests metastasis to rectouterine pouch, that is pouch of Douglas. So Blummer shelf will be in pouch of Douglas, Sister Mary Joseph will be periumbilical, Krukenberg will be to the both ovaries, Wichos node will be supraclavicular node. Okay. So next, coming to peptic ulcer. Peptic ulcer disease is divided into gastric ulcer and duodenal ulcer. Gastric ulcer mainly affects the antrum because there are where the G cells are present which increase the gastrin. So because of more gastrin, there is ulcer. Actually, what is ulcer? It is a breakdown of only mucosa layer, not beyond that. Sometime it can go even to muscularis externa, but first it need to break down the mucosa layer. So if there is more gastrin, that will happen. The pain can be greater with meals because if you eat more food, you will release again more hydrogen ions and that will lead to more pain, and also this associated with weight loss. 70% it is associated with H. pylori infection. Mechanism is decreased mucosal protection against gastric acid. Other cause, NSAIDs, H. pylori, smoking. Treatment is again, hydrogen pump inhibition. Risk of carcinoma is very much higher. It may turn into carcinoma. Biopsy margins to rule out malignancy may also lead to adenocarcinoma. Next, coming to duodenal ulcer, it is H. pylori, again most common because it increases the hydrogen ions. It involves mainly proximal duodenum, that is just after the pyloric sphincter of your stomach. Okay, proximal duodenum is most common. Decrease with meals. Why it decreases with meals? Duodenal ulcer because it is bicarbonate, right? So here if you eat more meals, more acid is released. If you here decrease with meals, weight gain because bicarbonate increase with meal. Okay, as you are eating meal in duodenum, it is the site where all the pancreatic enzymes and also biliary enzymes act, so there will be more bicarbonate, so it will decrease with meals, and 90% it is associated with H. pylori. So H. pylori is more associated with duodenal, but the pain will increase in the night in duodenal ulcer. There's decreased mucosal protection, increased gastric acid secretion, same for duodenal ulcer. Here important causes Zollinger-Ellison syndrome, which leads to gastrinoma, right? It is present in distal duodenum mainly and also in the jejunum. Generally, this duodenal ulcer is benign, not routinely biopsied because it's benign. And Brunner's gland hypertrophy is present. Why Brunner's gland hypertrophy? Brunner gland is present in submucosa of duodenum. It will undergo hypertrophy because of this ulcer. Because here the acid is more, so it tries to neutralize it by producing more bicarbonate. Brunner gland can do that, so it will undergo hypertrophy.